Okay, so now we are going to do DSM-5, and this is 130 slides. It combines several sections together covering various diagnoses and topics. And the reason why this presentation is so long is some preparation courses or classes, they may separate this in parts, but I put it all together and you can divide it up with whatever's convenient for you by either printing the slides or saving it to your computer. Everything presented in this presentation is important, and you should get an idea of everything. I know it might seem like a lot, and I am not trying to overwhelm you, but you do not want to be surprised on the exam. The exam only asks only a few questions related to recall of specific diagnoses. However, the exam will give you a lot of scenarios and questions where you will just need a basic idea of how long something might last for a specific diagnosis and so forth. I'll hit that up when we get to that point. Let's get started. So I'm going to go through quickly some of the diagnoses, skimming it over with you, and on your own time, you can look at them and see what works for you to process the definitions. But like I said, you don't have to learn all of these. Just get an idea in your mind, like the general idea of what it means. For example, non-suicidal self-injury. Well, it's kind of, if you break it down in your mind, you can memorize it in a little bit of a, oh, that makes sense, right? So this is somebody that is inflicting self-injury on themselves, but they're not suicidal, right? Just like it says, non-suicidal self-injury. This is like somebody who deliberately will, for example, cutting, dermatillomania, which is skin picking. They're going to be cutting or picking their skin until they bleed, but they don't want to die. They're just doing this because for them, somehow mentally, it's giving them some sort of emotional release. All right, so there's some changes to the DSM-5 that might appear on the exam. So just throwing it out there so you can just mentally like engrave it. Some of the material that I present also in the slides, it's good to know. I think that some test preps, like I've said in previous slides, they present information and they don't explain it. So you really don't, you're not really learning anything. Like you're just memorizing tidbits, and some people they pass, some people they don't. So I think everybody has a different style of learning, a different style of mentally processing things. And I think it helps people understand and memorize better if they understand it. So some changes to key disorders of childhood, and this is childhood only, okay? So the Diagnostic Statistical Manual of Mental Disorders, 5th edition, is what DSM-5 stands for, right? D stands for diagnostic, S stands for statistical, M stands for manual, and mental disorders, sorry. Okay, and then so 2 new childhood mental disorders were added to the DSM-5: social communication pragmatic disorder and disruptive mood dysregulation disorder. It's referred to, you're going to hear it as DMDD. So basically, their age-related diagnostic criteria changes for 2 other mental disorders. An ADHD diagnosis now requires symptoms to be present prior to the age of 12 rather than 7. And the PTSD includes a new subtype specifically for children younger than 6. So kind of what I recommend doing for all of these is just putting it in your mind. Don't beat yourself up if you don't know all the details, because it's not the goal here. I don't think it's good to just for me to have written 2 key disorders, childhood, communication pragmatic disorder, disruptive mood dysregulation disorder, and then ages, because you're not really going to understand, like, okay, what are these? What do they stand for? Which we'll go over further in other slides. Neurodevelopmental disorders have early onset. They start early. That's what early onset means. It means that they start early. So for a kid to be diagnosed with a neurodevelopmental disorder, you're going to see that early on in their development. And it affects their brain, the way that it processes. It produces impairments socially, personally, and occupationally and academic functioning, but they last for a lifetime. It's not like you can give them medication and the problem will almost go away. It's going to last a lifetime. They need to have symptoms and impaired functioning for these diagnoses. And some diagnoses of neurodevelopmental disorder are autism, ADHD, and intellectual developmental disorders. Now, adults can have ADHD as an adult and not even realize it till they're in adulthood, because a lot of people with ADHD, they had it when they were kids. And, I would say for us, I don't know, I guess people over, 20 maybe. I would say a while ago, ADHD wasn't really regarded for adults so much with so much attention. Now, like, if an adult says, I have ADHD, like, it's understandable that they probably had ADHD when they were a kid, but they got around it. Now we try to catch it in kids earlier on. Okay, so all the slides related to diagnosis will appear this way. I put them all in an Excel spreadsheet. I put the facts out, and then I went back and I added some question samples and little tidbits here and there. At the end, though, of this entire presentation, if you scroll down through the end of all the chapters on the left side tab, there's going to be a tab with links to websites, and those are hundreds and hundreds of free exam questions that I did the research and I pulled off the web from other sources, and questions that I had. So anyways, what I did is here, I did pull out the key facts that you should just kind of have an idea about. So intellectual disability, there's likely going to be questions on this on the exam. The exam does have a lot of questions about ADHD and learning disabilities. You will definitely see questions on the exam related to learning disabilities. So intellectual disability is now called intellectual developmental disability. So it's early onset of symptoms, right? IQ tests and adaptive functioning needed in order to diagnose this by a professional. Conceptual, social, practical, affected, a question sample style on the exam will be something like someone able to do stuff with assistance with basic skills, not major or profound, would be a 16-year-old with moderate intellectual developmental disability. So kind of read this over and get an idea. Intellectual developmental disorders are the next couple of slides we're going to go over. This is going to be disorders where you might be able to tell by facial features, and the exam may or may not. Like I said, I can't guarantee it because all of the exams are different, but just so you get an idea what you're looking at when you see something on the exam that might describe something, just to get a mental idea of what kind of developmental disorder you might be dealing with in the question. So Down syndrome is a neurodevelopmental disorder caused by problems with intellectual tasks, thinking, learning, communication, planning. It is, I believe, a genetic disorder, and it can cause difficulty with getting dressed or bathing. And people can think that they're acting out, but they're not. They just don't understand appropriate behavior. They're not acting out. So, like, I don't know if you've ever seen a kid in public, they're like, I don't want that. No, no, it's, and people are like, oh, what's wrong with that kid? There's nothing wrong with the kid. He or she has an intellectual developmental disorder, and that's just they're not acting out. They just don't understand appropriate behavior. So, you could get a scenario question where, it might be that a kid is acting out and like, no, this person has an intellectual developmental disorder. Global developmental delay is under 5 years old. This is a diagnosis given to a kid that's too young. They're unable to do testing for intellectual functioning. So a test question for this would be like a father would bring their child in who's exhibiting signs of developmental delay, and the therapist, or the treatment provider assesses the child, and they realize that this kid is under 5 years old, and the child does appear to have a disability of communication issues and intellectual disability, but they're not sure, and they're having trouble testing the kid because he or she is too young. So that diagnosis would be global developmental delay. If over 5 and the child cannot be tested due to a disability or communication issues, then it would be unspecified. So how do you get a diagnosis of intellectual disability? First, the child has to get an IQ test. A score below 70, not this diagnosis, is over 75. So if it's under 70 from an IQ test, then the child will have a diagnosis of intellectual disability. But if it's 75 and over, they do not have an intellectual disability. They're going to struggle with 2 or 3 things for kids: giving and getting, communication, speaking, and working with others on a daily living through living skills. Or it could be caused by injury or exposed to toxic items before the age of 18, shaken baby syndrome, or if they had an injury before they were born or after birth. Risk factors to cause intellectual developmental disorders can be caused by genetics, problems with child brain in the womb from drugs, alcohol, birth issues, later by a brain injury, potential child abuse, illness, seizures, and possible child neglect can all affect the brain, which could cause it not to grow and could cause intellectual developmental disorders. So there are many red flags and signs of an intellectual disability. For example, children may sit up, crawl, or walk later than other children. They may struggle with learning to talk or have trouble speaking. They can have trouble understanding social cues. They can have trouble seeing the consequences of their actions. They can have trouble solving problems or have trouble thinking logically. So a test question could ask, what are the signs? They could list maybe one of these choices and then 2 or 3 other ridiculous answer choices in like a sign of intellectual disability. So just kind of, I would say we already kind of know that. Most of us as social workers, or even maybe we've worked in doctor's offices before, we know that if a child's having, or if we're a parent, we know that if our child is having trouble sitting up or crawling or walking, we might be concerned about that. If we're a parent, we know that we have to take our kids to the pediatrician after so many months throughout their childhood development. And one of the things that pediatricians assess for in a pediatric visit is the child doing things that they're supposed to be doing at their ages of development? So sitting up, crawling, walking. If we're noticing that they're not doing that, the pediatrician usually does call it out as a concern, right? Sometimes the teachers also might bring it to the parents' attention that one of these things aren't happening, and that is a test question. There are a lot of questions on the exam that have you as a school social worker, and the teacher has brought to your attention that Joe Schmo Harry is having trouble understanding the cues of the teacher, and they're concerned that something might be wrong or the child may have an intellectual thing, and they bring the child to you for an assessment. So there are questions like that. So just kind of have an idea about this. So here are some genetic mutation disorders that happen. Remember, I had said Down syndrome. I thought it was a genetic disorder, and I just wanted to double check before I was 100% sure. I forgot about this slide. So these are 3 genetic mutation disorders that can happen, I believe, in the womb before the child is born. And just get an idea of the basics of them because it might be questions on the exam. So Prader-Willis syndrome is a very rare genetic mutation disorder that happens in pregnancy. It's basically the child is born with always feeling hungry. An example you can get is if, now everybody has TikTok videos diagnosing the life journey of their children. And I went on TikTok when I was first learning, I remember about Prader-Willis syndrome. And there are a few parents out there that have documented the journey. It's a really rough road for parents because they got a lot of negative feedback from people who have no idea what this is. Basically, they want society to know. I think it's fantastic, but still there's a lot of people out there that are ignorant. But Prader-Willis syndrome is basically, to my understanding, it's when a child is born feeling hungry all the time. Parents will have to lock the refrigerators. They just have to have their child on high alert all the time, watching them. They have to log their meals. It's a whole journey. Definitely go. You don't need a TikTok account to look at the videos. Prader-Willi syndrome, think of maybe Willie is always hungry. Like I said, I don't recommend mnemonics, but if you want to do little tricks like that to remember the tips on the diagnoses, because there are a lot, you can do that. Prader-Willi, Willie's always hungry. It's an urge to always eat. It's actually pretty sad. Kids will be very obese. They'll always be anxious. The hypothalamus in the brain does not tell them when they're full. They'll always feel like they're starving. And then this is kind of what kids with this diagnosis may look like. They may have almond eyes, light hair, turned down mouth. That won't be on the exam. I've never heard a diagnosis, description of the body, being on the exam, but, in case you were wondering, they may suffer from diabetes or sleep apnea if it's under controlled. These kids will appear on TikTok even undiagnosed, or you don't know about it, as those really, really, really obese kids. That's what this is. Fragile X is also a genetic mutation. It's when the X chromosome disorder happens during pregnancy. Most common signs of this are developmental delay, anxiety, difficulty with sensory information. It's more common in boys than girls. Boys have a lower IQ than girls. And then there's a description there of what it can do to the body and how the child can look. And then Down syndrome, it's also a genetic mutation disorder that happens during pregnancy. Kind of have a slight upward slant of the eyes, flattened nose, short stature. It's basically they have a partial or extra copy of the chromosome 21. It's most common disorder in kids, higher than normal heart conditions, respiratory conditions. Some go to college and some function poorly. I actually have a family member that has Down syndrome. She's so fantastic. She's very smart. She's an artist and she paints these beautiful paintings. But she's always going to the doctor for heart problems. She's had multiple heart surgeries, and she cannot take care of herself. Although she's in her late 20s, she functions at the level of maybe a young child, maybe, or a young teenager. So I would say someone with Down syndrome probably will struggle some, not all. I mean, I think I've seen shows where, um, you know, you could probably teach someone with Down syndrome how to live independently. I think maybe my cousin's parents baby her too much, but she's really, really smart. I think if she was given a chance to be independent in her life, I think she certainly could live an independent life. Fetal alcohol syndrome is alcohol from the mom in the bloodstream to the baby, and it gets the same percent of alcohol that the mom is getting. It can cause deformity, slow growth, learning disabilities, behavior problem, autism or ADHD. Your upper lip, it has a little, if you take your index finger and you tap your upper lip, you're going to feel you have that little um, slope that goes up and then down. Kids that do not have that, it's completely flat. It is likely, based on the definition of fetal alcohol syndrome, if you look at a picture, it says that they're missing that nasal bridge. So environmental factors can cause intellectual disorders. It can complicate pregnancy and cause problems. Communication disorders is true for all these disorders. It's a functional limitation, happens in childhood. It can be related to a medical issue. It's not autism. It's not intellectual only. It is communication. So communication, right? Okay. And it's going to be, these are the diagnoses associated with communication disorders. Remember, it's not autism and it's not intellectual only. It's got communication. Language, right? We know that that's related to communication. Speech, sound disorder, we know that's related to communication. Child onset fluency disorder is stuttering. Like, what did you say? Like something like that. That's stuttering. Also, I would say it's related to a communication thing. Social pragmatic communication disorder. That's a new diagnosis. It's also a communication disorder. Unspecified communication disorder. Also another communication thing. So they're all communication related. So I mean that can be helpful in memorizing these. Social pragmatic communication disorder, which I said is a new diagnosis, was created because a diagnosis might have been missing for people with the following symptoms. Problems with verbal and nonverbal communication for social purposes. Being unable to communicate effectively, struggling to communicate in life. Persistent speech issues. Speech sound disorder. A child has trouble saying certain sounds and words past the expected age. A child with an articulation disorder has problems making certain sounds the right way. A child with this process disorder will regularly make certain word speech mistakes. So speech sound disorder, right? It's saying here that this child has difficulty making certain sounds, right? So it's kind of like a common sense way to memorize this one. Child onset fluency disorder, stuttering, also called stammering or called child onset fluency disorder. It's a speech disorder that involves frequent and significant problems with normal communication. And then unspecified communication disorder would be unspecified. insufficient, right? You don't have enough information. I don't know if you've ever gotten like a lab work or a test and the paper, excuse me, said unspecified. It's because there's not enough information. It's not specific enough to make a specific diagnosis. They just don't have enough information, or something's missing. So that's what that is. Language disorder. Ongoing difficulty speaking a certain language, writing it, signing it, because they're having problems with understanding the production of the language. They'll usually have a reduced vocabulary. They'll have a word comprehension. So if the child is 10, they might only know enough of a 4-year-old. They have a limited ability to put words into sentences. They just struggle with connecting sentences together for a conversation. This is not caused by hearing or sensory problems. This is a language disorder. It is diagnosed early in life. So if you see that a 10-year-old is struggling with these things, which could be a test question, right? You're going to talk to the child, and you're going to see that this is a 10-year-old and they're speaking to you like a 4-year-old. This person has a language disorder. All right, so the next few slides are going to look like this, and these are summarizations of the disorders, of the diagnoses, so you can just engrave in your mind key facts. And like I said, I occasionally will plug in some more details where necessary. So autism spectrum disorder, there's a level 1, 2, and 3. They require little to most support, 0 to 5 years old. This is a social communication problem. And as the child gets older, they can lack companion skills. It's a repetitive behavior, such as hand flapping or things that they say. I knew this girl once. She had a form of autism, and you never would have thought that she had any limitation whatsoever. But periodically, if you look down at her hand, she'd just kind of like make that symbol when something's stinky. She'd just kind of like flop her hands, and it was part of autism spectrum diagnosis that she had earlier in life. And different cases may be more severe. Some may have, with this diagnosis, may have the need for fixed routines. They may struggle with having eye contact. They can have obsessed interests, like with snakes or some kind of toy. They can be hyper or hyposensory input sensitive, right? Hypo means little, less, and hyper means a lot, like hyper, like that's how you want to memorize things, with the word hyper in it. And they have a heightened sense. Their senses are. So that's the end of that first section, and now we're going to go into the next section. If you want to take a break here, you can take a break and put it on pause. So next is autism spectrum disorder. Deficits in social emotional reciprocity, ranging, for example, from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interests, emotions, or affects, or effect to failure to initiate a response to social interactions. So these are just some things here you can go over on your own time. These are some more details on autism spectrum disorder. Remember, you don't have to memorize everything. I'm just laying out all the details. So when you're memorizing autism, you can just think like abnormal social approach, failure to have like a normal conversation. They can have issues with nonverbal communication, deficits in developing and maintaining understanding. A good way to process some of the mental memorization of these diagnoses is watching YouTube videos where they explain in 5 minutes what it is. It'll help kind of bury the idea of like what these diagnoses might mean. You can also go to the websites on the bottom of all the pages where other research was obtained from. If you just want to read more about it, or maybe there's videos attached to get a better idea about what they are about. So social communication impairments, this is more about it. It talks about the symptoms. They start in early developmental period, and they can manifest later into complications with learning later in life. Basically, this is an impairment that affects social, occupational, and other important areas of functioning. So here's another little slide on social pragmatic communication disorder. Basically, you want to make sure that you rule out autism spectrum first. Social pragmatic communication disorder is an impaired social communication only. Remember, communication disorders are communication disorders. They are not another kind of disorder. They are social communication disorder. So social pragmatic communication disorder is impaired social communication only. You want to rule out autism spectrum, and it would not have repetitive behaviors. So the DSM-5 communication disorders include this new condition. If you hear me repeat things multiple times that I might have said already, I do that to just like bury it in your brain. So if you hear me say social pragmatic communication disorder is a new condition, and I said that 3 slides ago 2 other times, and you saw this word again multiple slides, it's just to present it in different ways. So social pragmatic communication disorder, or SCD, is a new condition for persistent difficulties in the social uses of verbal and nonverbal communication, right? And then it's present in early childhood. It's a new disorder. It cannot be diagnosed if social communication deficits are part of the 2 main characteristics of the new autism spectrum disorder. And then these are the 2 deficits. Specific learning disorder. You're going to have difficulty learning basic academic skills. You might have dyslexia or processing disorders. It may be more auditory or visual learner. You have to first rule out a learning disorder to help to not be a disruptive student or poor vision. Disruptive mood regulation disorder, formerly bipolar in children, is 6 to 10 years old or up to 17. The mood could be temper tantrums, and they have to have at least 3 temper tantrums per week. So the temper outbursts, they can manifest verbally, like a verbal rage. They can be physically aggressive towards people. Remember, 3 or more times per week. Irritability or angry most of the day or nearly every day for this diagnosis. It has, if the child has temper tantrums and the mood is kind of like outbursty, they have to have that for at least 12 months with 3 times a week of temper tantrums. This can happen at home, school, or with peers. And this diagnosis should not be made for the first time before the age of 6 years old or after 18. Now, one thing that I noticed is when I took the exam, I said, oh my gosh, I can't remember the ages. You're not going to ask you specific ages, but they're going to ask you like ranges for specific kinds of questions. And like I said, I can't tell you what's exactly on the test because I don't know what's exactly on the test. There are multiple tests, but with all the people that have taken the exam and passed, they have reported to me what they observed. And they did say that they observed a lot of questions on the exam related to kind of like the general criteria. So diagnosis for what we just talked about, it cannot coexist with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder. It cannot coexist with others, including major depressive disorder. So basically, when you're looking at a diagnosis, a good thing to remember is most diagnoses cannot be given if it's possible that another diagnosis exists. Remember to think in your mind that if you're looking at a specific diagnosis, you want to make sure that the question does not indicate anything else. The question sort of gives the answer. If the question states something like you're dealing with somebody that's sad or not eating, and there is a choice in the answer choice of major depressive disorder, attention deficit disorder, or autism, you know that being sad and not eating is not related to autism. It's not related to a learning disability. It's relating to feeling sad. So you're going to pick an answer most closely related to a diagnosis like depression. ADHD. This diagnosis is given before 12 years old, but an adult can have ADHD later if they realize they have problems with attention and hyperactivity. However, they've always had this diagnosis. So me, for example, I have ADHD. When I was a kid, nobody told me I had ADHD because, I don't know, I guess I was able to get by. You know, I didn't get the best grades when I was younger, and that was probably because I was struggling with maintaining attention, focusing. And I guess at that time, you know, nobody gave me that diagnosis, but now we're more focused on that. So ADHD, let's just say in a child would be diagnosed before 12 years old. You're going to have difficulty focusing at school or at home, or for an adult, it might be at work or even adult in school. Problem with attention or hyperactivity. You can't sustain attention or focus for too long. You might have difficulty with organization and task. You want to make sure you rule out a learning disorder. R/O means rule out. You could have difficulty paying attention, or you could have inattentive symptoms, or which is failing to pay attention, or you can have mixed type. So a persistent pattern of inattention or hyperactivity could be impulsivity that interferes with functioning or development as characterized by 1 and/or 2. So here we go. Here's just a little, you can just print this or take a picture of it with your phone. It's exactly what we just talked about in more detail, and it's just a graph for you to look at. And here's the same thing. This talks about inattention. If someone has a diagnosis of inattention, it's going to be a few of these, and then this is going to be what their limitation is. Hyperactivity. These are some of the symptoms of hyperactivity, ADHD. And this is just some things you can just, like I said, you don't have to memorize this. Just read it. Try to make it fun reading, right? You know, have you ever read like a magazine article or like an article online and you're like, this is so dumb, you know, this is so boring, but you read it and then you're going around telling everybody like, I just read an article about how frogs, you know, bury holes and whatever, and you remember everything. So this might not be fun reading, but take a picture of it with your phone and read it multiple times. I guarantee you some of it's going to sink in, and who knows, that might be a test question and you're going to remember this part. So here's impulsivity. And so there's, based on these types, right? So you got combined, which is both. So that's how you can remember that. Combined presentation, ADHD is combined. It's combined with inattention and hyperactivity, impulsivity. It's present for the past 6 months. Predominantly inattentive presentation. It's got the inattention, no hyperactivity, impulsivity, and it was present in the past 6 months. predominantly hyperactive, impulsive presentation, enough symptoms of hyperactivity, impulsivity, but not inattention, and it was present in the past 6 months. So because symptoms change over time, the presentation may change over time as well. So here it seems like they're all lasting for the past 6 months. All right, so now we're going into depression. So where you see the blue, the light highlighted blue, those are the different ones. So I'm just going to read you the different ones before we go into them. You got, and I kind of like listed them from like low to high, or, you know, like it's not really low to high, but like a range. So you got major depressive disorder, which is like the main one. And then you got unspecified, and then you got persistent. So major depressive disorder, MDD, that's the one that you're definitely going to see on the test. And that's the one that it's 5 or more symptoms present within the same 2-week period. And it's one of those symptoms. So a test question could be, Pickle has been having trouble sleeping and has not been eating well. And let's see. And you can say he doesn't feel motivated. That's 3. And he's feeling really sad. That's 4. And biological functioning, it could be something like his eyes have been feeling very sleepy. So that's 5 symptoms. And he's been feeling like this for the past 2 weeks since he broke up with his girlfriend. And then it's going to give you like a list of diagnoses, and then the diagnosis that you would pick would be major depressive disorder. These symptoms, remember, they just need to be 2 weeks. 5 or more symptoms for 2 weeks. Major depressive disorder. That's like the main one. That's like the one most people go through, right? When they just experience some kind of breakdown that is a bummer, right? You could go through a breakup, get fired from a job, something traumatic could happen in your life. And for the first 2 weeks, that's what you're going to feel, 5 or more of these. The next one is unspecified depressive disorder. That's a depressive episode that should not be diagnosed if there is substance abuse or medical disorder. This is basically like you don't really meet the full criteria of depression, but you're feeling off. You might have some symptoms, but you're not going to have any suicidal ideations. So this could be, maybe, I'm trying to think of a good example. This could be somebody who, you know, they went on a blind date and they really like this person. They've been chit-chatting with them on Tinder for a while and they really liked them. And then when they met them in person, the person didn't like them and they just feel like, oh, you know, I'm never going to meet somebody. This sucks. You're going to feel down, but you're not going to have 5 of these symptoms. You're just going to feel like shit. You know, you're going to be disappointed. You might be a little sad. That's normal. You know, this is not depression. You can't have a diagnosis. You don't meet the full criteria. Your functioning's off, but, and you're not thinking about killing yourself. So, I mean, it's none of these. Persistent depressive disorder used to be called dysthymia. Symptoms are in adults, it's 2 years or more, and in children, it's 1 year at least. Diagnosis is chronic, mildly depressed, on and off for 2 to 3 years. You have a lack of enjoyment and bored or low energy, low self-esteem. So persistent depressive, just think of persistent a lot. You're going to have these for a long time. 2 years or more for an adult, or 1 year at least for a child. And it could be on and off for 2 to 3 years for an adult. And then according to Beck, a depressed person does not see the positive aspects of his or her situation because of, and then, oh, so this is a question sample. So the ABCD. So according to Beck, a depressed person does not see the positive aspects of his or her situation because of, and then the correct answer would be a dysfunctional schema, because it says here a dysfunctional schema can occur when a number of maladaptive schemas are activated. A functional schema provides help and guidance in terms of problem solving and decision making. So basically, this is a sample of some of the questions that I'm going to throw in here, and you can just practice them. And then if you go to this website on the bottom, you can research more what each of these answers mean and more on this topic. So here's more on major depressive disorder. If you want to really dive in, since it is the most common tested depressive disorder, but like I said, persistent might come out there as well. So this is like a compilation of all the material related to major depressive disorder. You're going to have 5 or more of the following. And 1 has to be a depressed mood, and 2 at least have to be a loss of interest or pleasure. So here's the list. And then if you want a clear PDF link to this chapter, you can cut and paste this link right here, and then you can get a more detailed list. Persistent depressive disorder, which was the other one, which was the longer one, persistent. This disorder, remember, it's chronic. It's defined as chronic major depressive disorder or dysthymic before, but now it's persistent depressive disorder. It's for at least 2 years in adults or up to 1 year in children. And this is going to have 2 or more of the following. And so here is some more information about what we just talked about. I would say that a good way is to try to pull out oops, sorry, I clicked the slide too fast and I can't go backwards, but try to pick out the main ideas when you look at the details. Remember, don't try to memorize everything, but do your best in looking for the main points that you can jot down. So pica and rumination disorder. Pica, I don't know if you've ever watched, I remember there was a series that was on Netflix a while ago of like people eating carpet or eating their hair or eating chalk. This is a disorder of somebody eating non-food substances. And rumination disorder is when somebody has a disorder that when they eat, their food comes back up, they regurgitate it, and then they eat it again. And then we got language disorder and child onset fluency disorder, which we kind of touched on it earlier, but I just threw this in here. So just to recap, language disorder is a hard time building vocabulary. Again, usually in children, they might say something like me go to store. They can't say I went to the store or I'm gonna go to the store. That's an example of language disorder. Like they have a hard time building a complete vocabulary. So a 10-year-old might speak like a 4-year-old. This is from 0 to 5 years old. Child onset fluency disorder. This is stuttering or broken words. I understand you, right? That's stuttering, 0 to 5 years old. Just a recap of what we did. All right, now we got Tourette's disorder. I've also seen TikTok videos of young teenagers doing documentaries about their disability. So if you want to get some ideas more about what this is, it might improve like your learning style. Um, they add music and unfortunately, they make their disorder funny. I guess maybe that's the way that they cope with it, but I don't want you to see it as a funny thing. I want you just to maybe look at the TikTok videos as a way to learn. But Tourette's disorder, if you have both motor and vocal tics, um, you have Tourette's. So that's going to be physical or facial tics and also blurting out vocal tics. So Tourette's is when you have both. You both have physical and vocal. And then persistent motor vocal is only you have one or the other. So someone with Tourette's, they're not only going to struggle with twitching kind of tics, they're also going to struggle with vocal tics. You know, they might be like, you know, you're walking down the street and like, I hate you, you effing B, you know, they don't really think that about you. It's just a vocal tic that they have. Sometimes they just like walking down the street and like, you know, F-U-C-K, you know, and you're like, what? You know, it's just, that's what they do. So, and at the same time, they will have a motor tic going on. So that motor and vocal at the same time, well, not at the same time, but like having those two diagnosis symptoms is Tourette's. And then one or the other is persistent motor vocal tic disorder. Okay, so we got encopresis and enuresis. Encopresis is soiling of the pants, like pooping in the pants. And this is going to be over 5 years old, so that's why it's a disorder. So like the inability to wait to go to the bathroom, and this isn't some kids that have Crohn's disease may have difficulty holding in the feces, but that's a medical diagnosis. This is a mental health diagnosis, encopresis. This is difficulty holding in the poop and pooping in the pants over 5 years old. So maybe you can, encopresis has a P in it. Enuresis, you can think of urine. So encopresis is poop, and uresis, uresis is urine. That's urinating in your pants over 5 years old. Both over have a pattern of time, can be caused by trauma or sexual abuse. So if you are a social worker working at a facility or in private practice in the future, or you get a test question, and enuresis or encopresis is a choice and the other ones don't make any sense related to sexual abuse, it's going to be one of these. Also, if you're evaluating clients in the future and you're dealing with an adult or a child over 5 years old and they're having trouble keeping their feces and urine at the right time in the bathroom, you want to evaluate them for trauma or sexual abuse. This is a red flag. Separation anxiety disorder. This is an anxiety specific to separation. So you can kind of put that together. Separation anxiety disorder, anxiety from separation, from usually a caregiver. People can also have this towards their pet, leaving their pet at home, or a friend or someone that they're close to. But we're working here right now with people. This is an attachment disorder, feeling like constant worrying, clinginess to the person. You know, it's struggling with leaving this closeness. It's more common in children. And this diagnosis happens when it's happening for 4 weeks straight in children. 4 weeks for children, 6 months for adults. So if a child is feeling anxiety from separation from a caretaker, let's say he or she started at a new school and they're having major anxiety every time you drop them off at school for at least 4 weeks, then that child's going to have separation anxiety disorder. If it's an adult and for 6 months straight, then they're going to have difficulty coping. It's going to be separation anxiety disorder for an adult. Okay. So here is some of the symptoms related to separation anxiety, and you're gonna want to have 3 of these. So in order to diagnose a child with separation anxiety, you're gonna want to have 3 of these symptoms, or 3 for an adult. So this is going to be like recurrent distress, anticipating, I'm sorry, tongue twister, anticipating or experiencing separation from home or the attachment person, like worrying, worrying that they're going to be hurt, something bad's going to happen to them, or they're going to die. Worrying about maybe getting kidnapped or lost or having an accident because of the separation. Refusal to go out or away from the house because they're worried about the separation. Excessive fear or reluctance about being alone from that person. And difficulty or refusing to go to sleep because you're afraid of being separated from that person. Next, we got generalized anxiety disorder and unspecified anxiety disorder. So generalized anxiety disorder is worrying about a number of things. So it's generalized to various anxieties. Everything across, lots to worry. You're accompanied by physical stuff. It's like an example of you're having difficulty concentrating, you feel tense. 6 months for children and adults for this diagnosis. So this one is 6 months for both children and both adults. So it's not like different for children, different for adults. 6 months children, 6 months adults, general worrying, anxiety, restlessness, muscle tension, nausea, you're agitated, you're anxious. About general stuff, it can be a kid or an adult is worried about a test or worried about a field trip, or an adult is worried about a work meeting, or worried all about multiple things at the same time, or just different things, random, generalized anxiety. Unspecified, less than 6 months. You have some anxiety, but you really don't feel it like a criteria for the diagnosis. So maybe somebody is going to have a job change and they're anxious about it, but they've been feeling that way for less than 6 months. They don't really fit the criteria of worrying like a general anxiety for 6 months. So it's under 6 months, it's unspecified. So here is excessive anxiety and worry is an apprehension. Remember, occurring at least 6 months at work, school, or performance. The person finds it difficult to control the worry. And then here are some lists. The anxiety and worry, remember, with 3 or more of these symptoms, remember, for up to 6 months, in the past 6 months, 3 or more. And these are continued over. Next, we got selective mutism. Just think of mute, when you turn the volume off, and selective. This is the person just is refusing to speak in certain situations. So this is a failure to speak in specific social situations where there's like maybe an exception for like speaking at school. This is going to happen for at least 1 month. And this is the failure to speak, which is not due to a lack of knowledge or like some sort of communication problem. This is just somebody that like is selectively choosing not to speak. The disturbance is not accounted by a communication disorder, and it does not exclusively occur during a pervasive developmental disorder or schizophrenia. It's just like literally failing to choose to speak in certain situations. Next, social anxiety disorder. This is the fear of social situations. This person's going to be scared of being judged. They're going to be withdrawn and only stick to people that they know. They don't like being in groups. they get anxiety from being social with like new experiences. So according to the DSM-5, there are 10 diagnostic criteria for a social anxiety disorder. So all 10 of these need to last 6 months or more, in which a person feels a noticed observation or scrutinized by an adult, maybe a first date. In children, the avoidant behavior must occur in settings with peers rather than adult interactions, and will be expressed in terms of age-appropriate distress, such as cringing, crying, or otherwise displaying obvious fear or discomfort. So some examples of social anxiety disorder would be like being scared of being rejected. Talking with other people that they don't know might make them feel stressed. They'll avoid certain situations because they're going to be scared what might happen. They're going to be fearful and anxious about situations. They're going to be scared and anxious in social situations, persistent for 6 months or longer, and it's going to give them the feeling of like distress and impairment. The fear or anxiety cannot attribute to a medical disorder, substance use, or adverse medication effects, and it cannot be connected with another mental disorder. If another medical condition is present, which may cause the individual to be self-conscious, such as a facial scar, the fear and anxiety are either unrelated or disproportionate. The clinician may include the specifier that the social anxiety is performance situation specific oral presentations. So this means that these are the diagnosis criteria for social anxiety disorder. However, if the person has social anxiety disorder only because of a facial scar, or for example, there's a story that I follow on Instagram about a girl named Jackie who was attacked by a dog, 2 dogs, and literally the dogs ripped her face off, and she has a skin patch over her upper lip. She has openly discussed on her social media page. It's a I wouldn't share this if it wasn't a public thing, but it's a public journey social media page. That's a public page where she's sharing her journey of her recovery. She has vocalized that her facial challenges of her multiple surgeries that she's had has caused her a lot of anxiety. So she's not anxious around people. She actually has her whole social media page based around her journey. And I don't feel that this person has social anxiety around new people. Her anxiety related symptoms are related to her facial scar. So a clinician that sees a client and diagnoses them with social anxiety disorder would then need to document in that chart that the client has a situation-specific social anxiety disorder, right? So that's what that is. Reactive attachment disorder. So this is early on diagnosis between 9 months and 5 years. It results from persistent neglect, abuse, or multiple caregivers. This is failure to thrive, withdrawn, doesn't seek a response from comfort from others, and sits in the corner and does not engage. And I have to say, when I first studied these slides, this diagnosis, I started looking back in my life about all the times that I've actually seen kids do this. And now I do it all the time. And I had no idea that, that this kid that I saw, at a playground may potentially have been neglected or abused. So next time you see a kid that looks uncomfortable, they're not talking, they're withdrawn, they're sitting in the corner and they're not engaging, you need to look at that as a red flag. Disinhibited social engagement disorder. This is 9 months to 5 years, results of persistent neglect, abuse, or multiple caregivers. This person's going to stand out. They're not going to have any boundaries, and they're going to attach easily to people. Oppositional defiant disorder, ODD. Defiant, argumentative, problems with authority. Someone with this disorder is going to have major issues when they get older. This is going to flourish into a potential diagnosis as they get older, which can cause a lot of problems. And we'll get to that later. Well, we'll get to it now. I wasn't sure. I forgot if the slide was farther ahead. So oppositional defiant disorder, 6 months as evidenced by at least 4 of the symptoms. This person is going to struggle with losing their temper. They're going to be easily annoyed. They're going to get angry and resentful. They're very argumentative, defiant behavior. They're going to argue with authority figures. They're going to refuse to comply with requests from authority figures or rules. They're going to deliberately annoy people. They're going to blame others for his or her mistakes or behaviors. They might be vindictive. They're going to be spiteful or vindictive for at least 2 times within the past 6 months. So children younger than 5, the behavior should occur on most days for a period of at least 6 months, unless otherwise noted. For individuals 5 years or older, the behavior should occur at least once per week for at least 6 months, otherwise noted. The disturbance in behavior associated with distress the individual or others in his or immediate social context. So when I said that somebody with oppositional defiant disorder is going to have major trouble when they get older, they may have a hard time getting along with people in their job when given authority or directions. This kind of person can struggle with being annoyed easily. They may get mad easily. But overall, they're going to have a big thing with struggling to basically take direction from people. So yeah, that's the main thing. Conduct disorder. This is much worse than oppositional defiant disorder. This is pretty serious. Conduct disorder later in life can lead to antisocial personality disorder. And we're not talking, a lot of people get confused with antisocial personality disorder. Antisocial personality disorder, we're going to go over it later, is not someone that has maybe separation anxiety, right? Separation anxiety we talked about was someone that like kind of avoids interacting with other people. They're antisocial. Don't get confused. Antisocial personality disorder is not like not like social anxiety disorder. It's much more serious. People with antisocial personality disorder can sometimes be serial killers, but let's not jump the gun. Conduct disorder is someone that violates the law. They break the law, they're fighting, they're aggressive, and they lack remorse. So brief psychotic disorder, symptoms up to 1 month or 24 hours. So remember, brief, right? Short. 24 up to 24 hours or 1 month. Psychotic symptoms, delusions. For example, they're watching TV and they're like, oh, that movie star, he's in love with me. Like, we're gonna have sex later, like for sure. That's a delusion. Unless, you know, that movie star is your neighbor, you know, and you like really know them and you're like really in a relationship with them, then it's not a delusion. But if Brad Pitt's on TV and you swear by it, like you're not joking, this person's in love with me and like we're gonna have sex later, like you don't even know Brad Pitt, like that's obviously a delusion. But this is like a person that's like having a psychotic issue. This is not like you're joking with your friends, right? Hallucinations, visual or auditory, disorganized speech, you're rambling, you got disorganized behaviors, you have a flat affect, you're quiet. Delusional disorder, the main symptom is false beliefs, delusions, many types of specifiers. You falsely believe that you're being spied or your phone is tapped. So someone that's having a delusional disorder could be a symptom of schizophrenia. These are people who they may think that you know, the guy standing down the street, you know, that's a spy, or I can't talk to you on the phone because my phones are tapped. There's really no reason that your phone would be tapped. This is a delusional disorder. So here's a little graph that I made. Again, you can print it, share it, whatever you want, whatever will help you. Take a picture of it with your phone. This is a breakdown of the deets that you need to know for the 1, 2, 3, 4 of these. These are the main ones of the SCH family. It's not really a thing. I just invented that. So you got schizophreniform, schizophrenia, schizoaffective disorder, and schizoid personality disorder. So here I kind of listed like the main details about each one and how long they each are. You should definitely know that. Schizophrenia always is on the exam. This 1 or 2 or 3 of these things are definitely going to be on the exam, and it's not just recall. You're going to get scenarios where you're going to have a client that has schizophrenia and they're going to be presenting with symptoms. So know this pretty good. Schizophrenia for sure. I mean, maybe not on your exam. Like I said, I can't tell you exactly what's going to be on the exam, but they always test on schizophrenia. So pre-forming of schizophrenia, right? Form. Schizophreniform. See that in red there? Schizophreniform. A trick to remember schizophreniform. It's the before, form, like a forming. You're getting a ball of Play-Doh and you're forming a ball out of it. You're forming it of schizophrenia. So schizophreniform is consistent for 1 month to 6 months. It's like before you have schizophrenia, you're going to probably go through schizophreniform first, or you're only going to get to schizophreniform, right? It's the first thing, schizophreniform. Pre-forming, schizophreniform. It's consistent for 1 month, 6 months. You're going to have high stress, psychotic symptoms, delusions, hallucinations. You could have auditory hallucinations. You're going to have disorganized speech, rambling, disorganized behavior. You're going to have negative symptoms or a flat affect. You need at least 2 of those. So the forming of schizophrenia, 1 month to 6 months, 2 of those from the list, at least. Then schizophrenia, it usually begins before the age of 25 and is a lifelong illness. You're going to have a flat affect, consistent symptoms for over 6 months. So remember, schizophreniform is 1 to 6, and then schizophrenia is over the 6. And here you're going to be hearing voices, you're going to be hallucinating, seeing things, you're going to have psychotic symptoms, right? So all of these diagnoses, they all have more or less psychotic symptoms, right? This one's going to be delusions, hallucinations, auditory or visual, disorganized speech, rambling, disorganized behavior, negative symptoms. The same as the previous one, except the only difference is it's over 6 months. So it's not a lot of new things to memorize. Schizophreniform is 1 to 6 months forming and schizophrenia is over and you're still having the same symptoms. And then schizoaffective is you're affected in your mood. So not only do you have schizo symptoms, but you got an affectedness of mood. So schizo symptoms and you're now affected with mood disorder. So you have schizo, affective, you're affected. So you still have the schizo diagnosis symptoms: psychotic, delusional, hallucinations, disorganized speech, you're rambling, but you also got a mood disorder. So psychotic features present all the time, plus mood disorder in and out. Okay? So affected by mood disorder. That's a trick you can use to remember that. Then you got schizoid personality disorder. This is egocentric, egocentric. They're aware of this. That's what that means. They have a lack of interest in hanging out with others. They're considered loners. They have some feelings of depression. They might feel isolated, and this lasts over a lifetime. And just to click back real quick, for the schizophrenia, you need at least 2 of those, like schizophreniform. So these are some of the terms that I went over in the previous slide: delusions, false beliefs that are not based in reality, hallucinations, auditory, which is hearing, visual, which is seeing, tactile, which is feeling, olfactory, which is through the nose, smelling. These are kind of the things that you see on like a biopsychosocial assessment when you meet with a client and you're doing your assessment. There's usually check boxes there that you would check. You know, if they have an auditory hallucination, you're going to check that. Tactile, you're going to check that. Tactile, I think, would be like maybe they feel like spiders are crawling on them. Disorganized speech, they're saying things that don't make sense. They're using made up words that have no meaning or any speech. They're just jumping all over the place. You know, like I had a client once and he said, you know, that he was a general in a war and he was just going all over the place. He went from being a general in the war to, you know, a dancer, and he was just all over the place. So this could be an example. Grossly disorganized or catatonic behavior. They could be doing things like senseless movements, acting like doing silly things like a child would do, repeated movements for no reason. They could be pacing or walking in circles, talking to him or herself, or writing constantly, you know, whatever, like drawing multiple circles. All right, now we're going into bipolar. Same as the last slide, the highlighted in blue are the 3 different diagnoses. And then I highlighted in yellow some quick tidbits. And basically, this is what you need. So bipolar 1, you need a manic phase. You cannot have bipolar 1 unless you have a manic phase. Okay, so remember that. You must need a manic phase. You also need elevated mood for at least 1 week, irritability, doing risky things, maybe spending a lot of money. Those are just examples. Doing a lot of drugs, having a lot of sex. You don't need any sleep. You know, your moods are like, woo. And this can happen for several days. You may have an inflated sense of self-esteem, or it's also known as grandiosity. You can also be denial in this phase. Like, I don't know what you're talking about. Nothing's wrong with me. I just have a big project that I have to do. I'm really motivated. They don't see anything wrong. You need at least 3 of these for a bipolar diagnosis. But even if you had 3 of these and you didn't have a manic episode, then you would not have bipolar 1. And then you have bipolar 1 psychotic features, which are mood disorders, constant psychotic features in and out, hypomanic episode at least 4 days or longer, and mania 1 week or longer, or any duration that requires a diagnosis. Bipolar 2, hypomanic phase, 4 days, mild, 1 episode of major depression. You're feeling possibly less energized. You don't have like a severe problem in relationships, but for this diagnosis of bipolar 2, you're going to want to have this disorder if you're having past hypomanic episodes or past major depressive episodes. Cyclothymic disorder, This is chronic or mild mania, symptoms for 2 years, hypomanic and low level mood up and down. So remember, bipolar test questions, yes, you're definitely get bipolar. Like this is like a super common diagnosis that most people at some point in your life, you might treat someone with this. Bipolar 1, remember, you can only have that diagnosis if at least you have a manic episode and elevated mood for 1 week, and then you need 3 of those. So maybe someone that they're spending a lot of money, they're having a lot of sex, they're doing a lot of drugs, and definitely like no sleep, like that's a big one. Also an inflated sense of self-esteem, that's a big one too for bipolar 1. And then you could have also bipolar 1 with psychotic features, and that's what that is at the bottom. And then bipolar 2, you'll have a hypomanic phase, remember 4 days, a mild episode, 1 episode of major depressive, and cyclothymic, which is chronic or mild mania. You'll have these symptoms for 2 years. So cyclothymic, you can look at like you can maybe try to memorize this chart in your head and just kind of like think of it like bipolar 1, number 1. It's number 1 because it's the highest, right? Bipolar 1 is like the big one, mania, manic. And then bipolar psychotic features is psychotic features, exactly what it says. And then bipolar 2, and then cyclothymic. So whatever way works for you to remember these. This is a new one. This might be on the test because it's new. So prolonged grief disorder is the newest disorder that has been added to the DSM-5. It was released in March of 2022. This is when there's a loss of a loved one, and it had to have occurred at least 1 year ago for adults and 6 months ago for a child or adolescent. For this diagnosis, you're going to have intense longing for the person who has died or a preoccupation with thoughts of that person. In children and adolescents, their preoccupation may focus on the circumstances around the death. The individual is going to experience a lot of stress in their daily life. Persistent grief that's just disabling them every day, affecting their functioning. This is going to be prolonged grief disorder. They need at least 3 of the 8 below. They must have this one first. They must have a clinically significant longing and preoccupation of thoughts of the deceased. They could have the following 7, but they wouldn't have this diagnosis unless they had this. So remember, that's why it's in red. That's why it's giant font. They could have a million diagnoses in the world, but if they don't have this one, they don't have this diagnosis. To have this diagnosis, they must have a clinically significant longing or preoccupation of the dead person, right? I said the dead person, for a way for you to like really get it to sink in. Like I'm trying to use words to get it to sink in. So I think I said, instead of die by suicide in an earlier slide, I said, kill yourself. I don't mean to use intense words to be mean. I'm just using intense words to get it to sink in. So this person is thinking about this person who died all the time. It's like clinically affecting them. They cannot stop preoccupation of this person, thoughts, obsessed, like it's intense. And then on top of that one, then they need the other ones. It could be intense emotional pain, intense loneliness, an avoidance, a reminder. So two more of those. But if without this one on the top, it cannot be this diagnosis. Adjustment disorder. So we got reaction to something, it happens in the environment, life stressor, new job, divorce, symptoms within 3 months, and not beyond 6. This can happen, and a test question could be that the dad is in a new relationship since the divorce, and the child is having trouble concentrating in school or reacting somehow. The answer would be that the child was experiencing adjustment disorder if the question would say the symptoms have been lasting within 3 months, but not longer than 6. Then it would be adjustment disorder. Disruptive mood dysregulation disorder. This diagnosis is only in children. So just think of, maybe to remember it, you can think of kids can sometimes be disruptive, right? I guess that could be a way to try to tickle the memory in your mind of how to incorporate disruptive mood dysregulation disorder with something that will spark up remember, like something to remember, like what to connect it to. So disruptive, just think of kid, right? Kids can sometimes be disruptive. But the longer version of the diagnosis is mood dysregulation disorder. And unfortunately, this is persistent temper tantrums 3 times a week through different settings, at least for 12 months. So you can't get this diagnosis unless, and I think I talked about this one earlier on, but I'm just hitting it to you guys again, just so it sinks in. Remember, I may repeat slides of diagnoses, not to trick you or confuse you, but to kind of work on burying the memory in your mind to help you remember these. All right, going into panic disorder and agoraphobia. So panic disorder is reoccurring 4 or more times, having panic attacks. This is going to be fear of them happening again. Living in constant fear, heart palpitations could be one of the symptoms that someone can have. It could be dizziness. It could be sweaty palms, hand shaking. It comes and goes in random situations. 1 or more attacks followed by at least 1 month of fear of another panic attack or maladaptive behavior can be this diagnosis. So this is basically someone who's had a panic attack. They're going to be constantly in fear of when they're going to possibly have another panic attack. So they always avoid situations to not possibly bring on the possibility of having a panic attack. And then panic attacks with constant fear of a situation can then, a panic disorder can then lead into an agoraphobia from the intense fear. Sorry, dog's drinking water. Panic disorder can lead to later an agoraphobia from the intense fear of having panic attacks. So the persistent fear of doing things that like might cause a panic attack can cause what's called an agoraphobia. This can be the fear of going out in public or using public transportation, parking lots, supermarkets. Excessive impacts can cause persistent fear. You need 2 situations for this diagnosis. So fear of big or open spaces, closed spaces, movie theaters, or shops. They can trigger a panic attack for some. So I knew someone once with panic attacks, and I know that she later developed agoraphobia. This is basically a pretty big diagnosis that can really limit a person's life. So she had a panic attack early on in her teenage years. And then she started taking, I think, Xanax temporarily to control them. She learned a bunch of techniques to cope with them, but all her life, I think for like 10 years, I mean, even I think present day, she does have some limitations. She was always scared of having a panic attack again. She never really fully gained full control of her life. She did go into a little bit of an agoraphobia for a while. I remember that there was a period that she wouldn't even leave her house. but she worked with a therapist for a long time doing cognitive behavioral therapy, and I believe she did exposure therapy, which can be really helpful in treating clients with panic disorder. So just remember that if you see something on the exam, like what intervention might be best to treat somebody with panic disorder, the type of intervention would be cognitive behavioral therapy, exposure therapy, prolonged exposure therapy. That is basically having the person do small things to work through retraining their brain that a symptom is safe. So someone with panic disorder might do an exposure of who cannot leave their house by one exposure would be standing by the window and looking out the window. That's how severe and debilitating this diagnosis can be, where a person may not even be able to stand and look out the window because it will trigger symptoms like dizziness. Someone can even have what feels like a seizure, which is a panic attack. So if you want to read more about this, just Google it. But there are some movies too. I think I don't remember 100% what it's called, but The Woman in the Window. And then there was a comedy version of that movie. Um, but even those movies, I don't think fully depict the diagnosis. Maybe a YouTube video, or maybe you can find something on TikTok. But this is a pretty severe diagnosis to have. This can be caused by children who grow up in environments where there's a lot of arguing, or maybe even abuse between their parents. It can cause a feeling of being in constant fight or flight, which can cause dysregulation in emotions. Obsessive compulsive disorder and obsessive compulsive personality disorder. So both of these diagnoses are related to obsessive thoughts and compulsive behaviors, but one is worse. Obsessive compulsive disorder is mostly like an impairment ability to function, like overly hand washing, which can actually lead to someone's skin on their hands falling off, or an obsessive use of hand sanitizer. And hand sanitizer, I'm sure some of us have realized from the pandemic just happening, if you use too much of it, the chemicals will actually burn your hands. And can cause a chemical burn. I mean, it happened to me from one of the hand sanitizers, using it all the time, and all of a sudden the top of my hands got really dry, like alligator dry, and they started to really hurt. It was actually a chemical burn from the alcohol or whatever is in hand sanitizers that kills bacteria. So somebody with an obsessive compulsive disorder may, for example, use hand sanitizer so oftenly because they have a fear of maybe germs or compulsive intrusive thoughts about bacteria that their skin may fall off. Next, obsessive compulsive personality disorder is more like that movie with Julia Roberts, Sleeping with the Enemy. That's somebody who's a perfectionist. They're really rigid and controlling. In that movie, if you haven't seen it, you should definitely see it. It's a really good movie. It's called Sleeping with the Enemy with Julia Roberts. It came out, I think, in the 80s or 90s. And it's basically about her marrying this guy who she thinks is so amazing. And then it turns out that he has obsessive compulsive personality disorder. When she doesn't organize things the way that he likes, in his perfectionist manner, he'll physically assault her and then just display some unstable behaviors. And these people can function normal in society. He looked like a normal guy, but he actually had this personality disorder. Dependent personality disorder. This is somebody that has difficulty making decisions without advice from others. They have a fear of loss of rejection if they don't agree. They don't speak up, they don't argue, they go along. They're like people pleasers, they lack confidence, they take on unpleasant tasks so that they'll be liked. They feel alone and uncomfortable and helpless if they don't have someone there to help them. They're always jumping in and out of relationships because they want to feel cared for and taken care of. They completely rely on someone else to take care and think and decide for them. So if you've ever known somebody that cannot be single for too long, they may have some symptoms of dependent personality disorder. This is somebody who, usually like, where do you want to go to dinner tonight? And you say, I don't know. No, you decide. No, but I don't know. No, you like, they want you to make the decision. I'm not saying that's a bad thing. I mean, maybe somebody really wants their significant other to make the decision. This is like a disorder. So this is like intense. So maybe don't compare this to that example that I just gave. But this person is going to feel like just completely uncomfortable and helpless unless the other person helps them in everything that they do. There was a test question on my exam that I remember, something like a student in college needed help from the advisor to select her courses, and because the advisor was unavailable, she just totally freaked out because she needed the advisor to help her make the decision for the classes. And it gave a bunch of choices, and the answer was dependent personality disorder. Like, the student could not make any decisions on her own. She needed the advisor to make the decisions for her, and without the advisor making the decisions, she felt helpless and she didn't feel like she could like function in school. So it's like pretty severe. Usually former inmates may struggle with dependent personality disorder, especially former inmates with substance abuse. You may hear that word, I'm codependent, and this is because they may be struggling with dependent personality disorder. Next is acute stress disorder and post-traumatic stress disorder. So acute, within a month of the incident. Post, at least 1 month has already gone by, right? So think of post, like past. Acute, think of present. Okay, acute, within a month of the incident. Post, at least 1 month after the incident. So acute, within 1 month of, for example, somebody being raped, they're going to have acute. If 1 month has already gone by since they're raped, they're going to have post. So acute stress disorder, 1 month of the incident, it's a life-threatening incident, or they witnessed it. They're going to have intrusive thoughts and memories, flashbacks, nightmares, depression, irritability. Maybe not all of these, but a few. They're going to feel guilt or maybe survival guilt. They're going to avoid the location. They're going to feel hypervigilant and arousal. I had a test question that I know for sure I got wrong. It had asked me what was a symptom of a person who had been jumped in the street, and now every time they walk down the street, they're scared. And it gave like a bunch of diagnoses, and then it said hypervigilance. And guess what? I picked PTSD. It wasn't PTSD. They asked for a symptom of the diagnosis. They didn't ask for a diagnosis. So remember to read the stem of the question really, really good so you know exactly what they're asking for, because when you're in full-blown test mode and you're reading all this stuff and you see hypervigilance, acute stress disorder, post-traumatic stress disorder, irritability, and they ask for something of a symptom, you may not comprehend in that moment that they are not asking for a diagnosis. They are asking for a symptom. So you might get scrambled, you picked the wrong thing. So go slow and see what they're asking. Write on the whiteboard what they're asking, so that you look down. They are not asking for a diagnosis. They're asking for a symptom of a diagnosis. Okay? So PTSD is 1 month after the incident. It's same thing, same symptoms, but it's just the time is different. So like, here is a sample question. A soldier, so this, I'm going to do it how I want you to learn it. You read the last question. what is the first thing you should do? They want to know what's the first thing you should do. Then you go back. A soldier with combat-related post-traumatic stress disorder desires to return to combat. What is the first thing you should do? Then you read the answers. A, allow the soldier full self-determination, returning when he deems appropriate. B, inform the client that return will likely cause an increase in symptoms and is not advised. C, contact the commanding officer to determine if this is an option for the soldier. Or D, assess progress in treatment and current level of functioning. So what's the first thing you should do when a soldier? So you're a social worker and you got a soldier with combat-related PTSD. He wants to come back to combat. What's the first thing you should do? So go through it in your head. Pretend. Yeah, sure, go ahead. Yeah, okay. Yeah, self-determination. You just let somebody with PTSD just like go back in. So A is no. That's ridiculous. B, well, if you go back, you're likely going to have an increase of symptoms, so I don't think you should. Do you think that you would say that? Do you think that's best social work practice to talk to somebody like that in therapy? No, that's not cool. Don't do that. C, contact the commanding officer to determine. You would not go behind the client's back and say, hey, commanding officer, Joe Schmo here wants to go back in combat, but he has PTSD. Is this an option for this? No, you wouldn't do that. You're going to do D. You're going to assess. You want to see how he's doing. You want to see how the treatment is working. You need to first find out information. You're not going to jump to A, B, or C. You're going to do D. Okay? So that's that. Adjustment disorder with anxiety. This is anxiety linked to an event, not life-threatening. Change in life, lots of stress, no nightmares or flashbacks, just anxiety. With anxiety, it's called a specifier when added to a diagnosis. So you got adjustment disorder and they've added what's called a specifier, and that's what that is. With the W/ stands for with anxiety. So basically what this slide is saying is that this is a person who has adjustment disorder with an added specifier, that's the W/ anxiety. All right, let me take a sip of water. Talking for an hour and 45 minutes. Here we go. All right, we got delirium. We are on slide 77 of 130, so feel free to take a break anytime you want. You can just pause this, maybe write down how many minutes you're on in case your computer shuts down by accident. Then you can just jump into the video to this slide. Deep breath. Delirium. This comes on quickly, hours of the day, shifts in awareness. This is usually caused by a medical illness. So someone doesn't just have delirium. Delirium is usually caused by somebody that is having some sort of maybe an infection or medication caused it. They're going to have reduced awareness, memory impairment, behavior or emotional changes or hallucinations. These are the different types of delirium. Remember, hyper means a lot, hyper, restless. Like, it's going to be a lot. Hyper, 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 hyper. Active. Hyperactive delirium, people with this type may be restless and anxious. Hypo, right, like hypothyroidism, is low. People with this type may be inactive or have a reduced activity. They tend to be sluggish or drowsy, kind of in a daze. And then mixed, obviously, is both, right? The person may quickly switch back and forth from being restless and sluggish. Next, we got neurocognitive disorder, mild cognitive disorder, and major. So, kind of like they're in an order, the way you can mentally process them. You got like neuro, mild, major, right? That's kind of like you got the BAM, the middle, the big time, right? So neurocognitive disorder is effects of the cognition of thinking, reasoning, altered awareness, and is reversible. Then you got mild, which is kind of in the middle. This is a precursor to major, obviously, because major is next. This is a noticeable decline. You can live alone, but you might need some help. It's progressive and it does not get better and it is not reversible. Major, right? This is formally called dementia, is a serious issue with attention, executive functioning, cognition, motor skill decline. Major, this person's going to be probably in a nursing home. They cannot live alone and they're not getting better. Somatic symptom disorder and conversion disorder. So this is somatic symptom disorder is where there's one or a physical symptom from stress. They devote a lot of time on it. It impedes their functioning. It's present for 6 months. There's no medical reason or physical symptom. It's just stress related. So this is like you go to the doctor and you're like, I have this pain in my shoulder, and the doctor's like, well, I can't find anything wrong with you. Like, this is a somatization most commonly caused by a mood disorder that threatens mental stability. And then you got conversion disorder, which is really rare, and it occurs when the somatic presentation involves any aspect of the central nervous system over which voluntarily control is exercised. So this is like a psychological stressor converted into a non-real diagnosis. Like a person that's in a blind rage may actually become blind. It has to be neurological. It's neurosensory symptom with sensations or movements. Illness, anxiety disorder. Rarely a somatic symptom. It's mild. This is an intense fear that they may have a disease, like kind of like an hypochondriac. And this is present for 6 months. All right, so these are the ones about like faking sickness, being sick. These are the ones. So you got factitious disorder, and then you got factitious disorder by proxy, which used to be referred to Munchausen, and then you got malingering. So I grouped them all together because I feel that they're all connected into their awful diagnoses. So factitious disorder is when you're imposing it on yourself. This is when the person acts like they're sick, but they're just faking it because they want attention. They want people to feel sorry for them. That's factitious disorder. Factitious disorder by proxy, which used to be called Munchausen, is when a person makes someone else sick. They impose sickness on someone else. This is reportable. And a good movie to watch for an example of this is the story of Gypsy Rose. I can't believe, I didn't even really know that this existed. Another one that's good is The Sixth Sense with Bruce Willis. This is when, for example, a mother intentionally pours, in The Sixth Sense, the mother intentionally poured Pine Sol cleaner in her children's soup that she was giving her until she died. And it was, I think the little girl knew that her mom was making her sick, so she put a hidden camera in her room, which caught on video the mother poisoning the girl, which later helped solve like the case. I won't tell you any more details if you haven't seen it, but it's pretty moving. And then the story of Gypsy Rose, that's a true story about a girl whose mother made her child go through cancer treatment and all kinds of things, and she never had cancer. She made her take all these medications and put her through horrible things to fake various diseases so that the mother could get money from disability. And they also wanted attention. The mother wanted attention, not the child. She got on like live TV and various charitable events, YouTube videos that you can even watch that are still out there, where you see this child sitting in a wheelchair and she can really walk, but the mother made the child believe that she couldn't and that she was sick, and she wasn't. So that's factitious disorder by proxy, used to be called Munchausen. And if you suspect that a child is somehow a victim of this, this is definitely reportable. Malingering is faking an illness to get out of work or to get Social Security or gain some kind of something from avoiding something. So that's why they have insurance investigators and, you know, different people with investigating things before they give money, because they want to make sure that this person isn't faking, you know, I can't move my neck from a car accident to get money from an insurance or something, because they're trying to gain something from or avoid something. All right, now we are going into eating disorders. Anorexia nervosa, bulimia, binge eating. So anorexia nervosa is restricted dietary intake. Person's going to be very thin. They're going to have an intense fear of gaining weight. They're going to have probably body dysmorphia, like a distorted view of being overweight. They're going to exercise a lot. They could have an exercise addiction. They're going to need a higher level of care. So if you're going to work with a client that has anorexia nervosa, you're going to want to make sure that you have permission to speak to their medical provider, and you're going to want to work hand in hand with their medical provider with any cases having to do with a client with anorexia nervosa. Bulimia, you need two things. This is eating more or feeling out of control, compulsive eating, reoccurring purging, vomiting or puking, however you want to memorize it, that works for you. Binge eating is only engaging in binge eating, no puking, no vomiting. So you cannot have binge eating disorder if you are doing anything related to bulimia. Binge is its own diagnosis. So only binge eating, like that's eating a large amount of food, totally being unable to stop, like eating a giant bag of potato chips that's maybe 283-gram potato chip bag, eating maybe 2 bags of it and totally being unable to stop, and then after feeling disgusting and shame. That's binge eating disorder. Okay, and then like I had mentioned body dysmorphia, that's like when you look at yourself in the mirror and you just feel like totally displeasure of a body part, like you really totally hate your nose or your ears. It might not be related to weight, but when you look in the mirror, like you're just so disgusted with something about your body. Unspecified eating disorder, it doesn't meet the criteria of anorexia or bulimia. So like I had mentioned before, it's going to be unspecified. All right, so now we're going to go into some diagnoses about like gender. So another diagnosis is called sex and gender diagnosis features. This is going to be gender dysphoria. Natal sex, it used to mean the sex you were born with. To the birth assigned gender. Natal male or natal female is now called an individual assigned male or female at birth. Gender reassignment treatment is not gender affirming treatment. Desired gender is now experienced gender. Non-transgender and transgender people is a specifier post-transition after gender affirming surgery. Gender has nothing to do with sexual orientation or sex or sexual expression or gender expression. They are all different. a lot of people get confused with that. So if you have to Google it to learn more about it, I recommend looking into it. There definitely will be things on the exam related to gender identity. There's a lot of LGBTQ stuff on the exam. There's going to be a lot of terms related to gender identification, sexual orientation, sexual expression. That's a big thing because there's a lot of confusion around that and there's a lot of changes to that. So they want to make sure you know how to address clients properly and respectfully. So remember, gender has nothing to do with sexual orientation or sex or sexual expression or gender expression. They are all different things. Next, depersonalization. Derealization disorder is reality intact, present, feel outside of their body. They do not feel connected and they feel maybe surreal. Dissociative amnesia disorder is suddenly forgetting, extreme stress or shock. They may even forget their address. Dissociative identity disorder. This is multiple personality disorder. This is kind of rare. This is someone that may have 2 or more personalities. They can't remember the other person. This may be caused by extreme trauma at a young age. Genital pelvic pain and penetration disorder. So some of these, remember, they may not be on the exam, but these are common disorders that have appeared on the exam. And when I include diagnoses, I sometimes add more as students tell me what appeared. So at some point in time, some of these diagnoses appeared on the exam, and so I add them in. So, you know, like I said, don't try to memorize everything, but just get a general idea. A lot of these diagnoses kind of like have words in them that make them kind of seem like common sense. So just try your best, just memorize the basics, but like don't go crazy trying to memorize everything. Pretend like you have an exam like in college or something and you have to learn the definitions. Try your best to memorize the basics about the definitions, but also don't memorize everything because you're going to have to apply it in scenarios. So you're going to have to like know how to break it down into actual situations. That's why I say don't just memorize the definitions. In your head, you know, if you have to close your eyes or look around next time you go to Starbucks or to the store and diagnose people based on what you observe. That's going to help you identify the way things might appear in a question. Genital pelvic pain and penetration disorder. This is obviously pain during intercourse. This is displeasure about having sex. This may be caused from domestic violence, rape, or trauma. Female sexual interest arousal disorder. This is no sexual thoughts or fantasies, temporary or permanent. Okay, next we have insomnia, nightmare, central sleep apnea, narcolepsy. These are all eye or sleep or somehow sleep related disorders. Insomnia, we all know what that is. That's difficulty sleeping. And in someone with this diagnosis, they're going to have 3 nights per week for 3 months, waking up multiple times. But you're going to want to rule out a manic phase, like bipolar 1. You're going to want to rule that out. You cannot have bipolar 1 and have insomnia because insomnia obviously is going to happen from somebody with bipolar 1 because they're probably not going to be sleeping. You also want to rule out major depressive disorder because if somebody has major depressive disorder, they are probably going to feel some difficulty sleeping, so they cannot have both. Nightmare disorder, this is someone that wakes up several times and has nightmares and they can remember the nightmare. Central sleep apnea, this is when someone stops breathing when they're asleep for up to a minute. It disrupts the quality of sleep and it can make somebody feel really tired in the morning. I believe this is people that have those little machines that they use. I think they help them breathe. I forget what they're called, but I think that's what that is. Hypersomnolence disorder, that's excessive sleepiness. This is someone that likes to sleep 7 hours or 9, 10 hours or more, but they're going to feel tired or sluggish. They're going to be overweight, but make sure you rule out major depressive disorder and substance abuse. Non-rapid eye movement disorder. This used to be called sleep terrors. This is reoccurrent waking. You can't remember. You don't fully wake up. You're sleepwalking. A good example could be stepbrothers. That's when they sleepwalk at night and they put all the pillows in the oven. That's an example of sleepwalking, but I don't think that they have sleep terrors, so maybe it might not be 100% the same. Narcolepsy, this is a sudden attack of sleep, sudden loss of muscle tone, and daytime fatigue. I think that's people that just like suddenly fall asleep. Intermittent explosive disorder, this is problems controlling aggressive impulses. They're verbally abusive, compulsive. They can't have any other diagnosis. This is just marked by aggression, and they cannot be drunk. Kleptomania, this is like compulsive stealing. They get a rush from doing it. Trichotillomania, also known as trick. This is when someone cannot resist the urge to pull out their hair. This is a compulsion disorder. It often happens when someone experiences abuse. It could be verbal abuse or trauma. They have relief from the worrying thoughts from the pulling or the sound of the plucking. This can be due to self-inflicted punishment for shame or guilt. It can provide a relaxing feeling. This can cause bald spots. I've also seen TikTok videos of this. This is something that people do document their journey. This never goes away. It can develop from 10 years old, 13 years old. It's a lifelong thing. It's just one of those things that you learn to cope with. It's like an impulse control disorder. It's a body-focused repetitive behavior. You might see that sometimes BFRB behavior. This is it's like a nervous thing people do. Someone with skin picking, if you see someone always like kind of picking the scabs on their face or their acne, they're constantly picking their acne on their face. That's a body focused repetitive behavior. That's a disorder. People don't realize it, but if you're constantly picking your skin, picking a bump on your skin, you're always got your fingers on your face, your back, your neck, your shoulder. That's called dermatillomania, and that's just a body focused repetitive disorder. And it's just caused by anxiety, abuse, or trauma. Substance use disorder, mild or severe, failure to meet obligations. It impacts social interactions. You can feel withdrawn without it. Substance-induced disorders, you got substance intoxication, you're on it, or substance withdrawal, you're getting off of it. Right. Then you got gambling disorder. That's an easy one to remember. Compulsive gambling, increased spending. You're looking back, you're like, oh my gosh, I just spent my whole life savings. I'll win next time for sure. This is an issue, right? You spend all your money, you get really stressed, you got people after you because you owe them money. You're gonna lie about your gambling. Make sure you rule out a manic episode because remember, bipolar 1, they might start engaging in risky behavior like gambling all their money away. Okay, ego syntonic and ego dystonic. Whatever way works for you to remember these. This will be on the exam. Ego syntonic, it's a part of the view of self. You don't have an issue with it. It's developed early in life and you accept it. You accept yourself being ego syntonic. Ego dystonic, the client is aware of it and does not like it. Panic disorder, for example, anxiety with panic disorder. This person's ego dystonic. They know it's there and they don't like it. Even someone with trichotillomania, they pull their hair out until they're bald in some spots. They understand, they know that they have trichotillomania. They're aware of it, but they do not like it. They're dissing it. They don't like it. It's a diss. They don't like it. Ego syntonic. They know they have it and they're totally cool with it. They accept it. I guess like a sinner. They know they're sinning and they are fine with it. Whatever way you can remember that. Paranoid personality disorder or delusional personality disorder. So paranoid personality disorder, rational suspicion, long-term mistrust of others, constantly thinking people are trying to deceive them. They read into things a lot. They hold grudges. I mean, they make it sound really harsh here, but I mean, I think all of us have been paranoid at some point. And shit, it's a disorder. I mean, I don't think that I've been constantly thinking that people are trying to deceive me, but I've definitely used the term I'm not being paranoid or I'm being paranoid. I'm not being paranoid. We've all said that probably. I'm not being paranoid, but so this is when somebody has a suspicion. I'm sure this is a much more extreme to have a disorder. This is like someone that like absolutely doesn't trust anybody. They always think that people have some sort of ulterior motive or intention to hurt them somehow. They can also have delusional disorder, which is delusions, bizarre, non-bizarre. You only need one thing for this diagnosis. You might feel like you're being followed or the aliens are going to abduct you. Avoidant personality disorder. These people are lonely and sensitive. They're scared people won't like them. They avoid social interactions out of fear and they want to connect. They may feel so overwhelmed with fear that they just like will avoid them. So remember, avoidant personality disorder is someone that's lonely. They're scared that someone won't like them. So they do want to meet people, right? They do want to make friends, but they're so terrified that somehow people are going to like not like them or reject them that they just avoid the situation. Um, Schizotypal personality disorder. This is someone that might have oppositional defiant disorder or thinking. A good example of someone with schizotypal personality disorder would be Willy Wonka from Willy Wonka and the Chocolate Factory. He had like kind of an odd behavior. He also kind of had an odd way of thinking and he had magical thinking and he was suspicious of people. He didn't have close friends and he really dressed kind of oddly, or, you know, different, not like most people dressed. That's schizotypal or schizotypal, like however you want to learn and memorize the word. I think the correct way to say the word is schizotypal. When you think of type, right, schizoid type, you can say Willy Wonka is schizoid typal personality disorder, whatever way you can engrave it in your brain. And when you think of Willy Wonka, think of Willy Wonka and the Chocolate Factory, which was super cool and magical and odd and just super eccentric. And that's this diagnosis. Slide 97 of 130. We're halfway, almost more than halfway done. I'm scared to pause this video because I don't want something to happen where I'll lose it. So I'm going to keep going with you guys. Let's keep going. All right. Antisocial personality disorder and narcissistic personality disorder. Antisocial personality disorder is 18 years old for the diagnosis. Evidence of chronic disorder by age 15. Pattern total disregard of the rights of others since the age of 15, deception, lying for pleasure, aggressive recklessness, lack of remorse, and they don't feel bad. This is a very dangerous personality. This is, there's this diagnosis on several movies that I've seen of murderers. So this diagnosis can be dangerous. I'm sure someone with this diagnosis can probably get along fine in the world, but they just probably have to keep things in check. Narcissistic personality disorder, grandiose sense of self, lack of empathy, rude, snotty, and not see impact to others. They can be exaggerated achievements, fantasies of power, sense of entitlement, envious of others, rage if challenged or put down. We've all probably compared somebody in our life or someone we dated as having narcissistic personality disorder. So that's that one. Borderline personality disorder. This is someone who's going to think black and white. They're going to be fearful of abandonment, suicidal, recurrent gestures. They can love their therapist and hate them. They can struggle with their identity, moody, instability in relationships. When you're working with, this is definitely going to come up on the exam. Borderline personality disorder always appears on the exam. A big thing about borderlines is they struggle with maintaining good boundaries. The therapist needs to establish good boundaries. The best therapeutic intervention when working with the borderline is dialectic behavioral therapy, DBT. Borderlines, they really, really struggle. Like borderlines in mental health, they have like this really like bad name. And whenever people talk about borderlines, they're so like, I've heard people speak so negatively. But borderlines, I believe, develop this diagnosis because they may have experienced sexual abuse or some kind of abuse as a child. They may have struggled really hard with connecting with a caretaker and like probably been abandoned a few times. And they really had a hard childhood. And so unfortunately, it develops into these other symptoms. So if you're working with a borderline, like be patient, set clear boundaries, and communicate really clearly the expectations. Because I think they need this because they've had such rigid connections earlier on in life. Histrionic personality disorder. This is, I heard this from another teacher, I don't remember who, Anna Nicole Smith. I'm not trying to make fun of anybody, of course. I'm just trying to use an example for educational purposes. Even actors and movie stars that you see like in the world now, histrionic personality disorder. I can even think of like someone from college. This is someone that loves attention. They need to be the center of attention. They got to dress super sexy. They act sexy. Those Bling Empire shows on Netflix, like I think of histrionic personality disorder and a Nicole Smith show. Rapid shifting of emotions. They're very vain and dramatic and exaggerated. That's going to be histrionic personality disorder. So here's a practice question. So there is no last sentence in this kind of question, it's just one full sentence. So you obviously wouldn't read the last question because it's just one sentence. So when someone fakes having a mental or physical illness without any obvious external rewards can best be defined as. So like you look, you're like, I know it's fictitious or boom, and I'm gonna pick C. But don't do that. Read the choices and read again what it's asking for because it could say which is not. So you wouldn't pick fictitious, you would pick something else, right? So make sure they're asking for the best. Okay, they're not asking for which is not. They're asking for the best. So you're going to say A, malingering, B, sociopathy, C, factitious disorder, D, schizophreniform. Tell yourself, I know it's C because schizophreniform is you're forming schizophrenia. So it's not that because that's schizophrenia related. That's not faking a mental illness. So now you have three choices. It's not sociopathy. It's either malingering or factitious. So you would strike out on the exam. Don't do it if you don't need to do it, right? You don't want to waste time. Don't using the strikeout, but at least I mentally say, all right, it's definitely not B, it's definitely not D, it's either A or C. Or malingering, remember that's faking a sickness to gain something. And then fictitious disorder was faking an illness for attention. So that would be fictitious disorder. All right, suicide, homicide, and risk factors for suicide. Now, there's a whole other presentation in here that we're going to do on suicide and risk factors, but I threw on this slide just because, we're doing DSM-5, and I just wanted to let you know. Suicide, homicide, and risk factors for suicide. Ask, ideation, intent, plan, behaviors. For example, do you think about hurting yourself? So you would ask a client this. Like, do you have ideations? So how likely is your intent that you want to do it? Do you have a preferred method or plan to hurt yourself? So that's what you would do if you had a client that may have a risk factor for suicide. So here's a practice question. You're going to read the last question. The last question is, the social worker's first response to this information is to, so a social worker just got some information about something. A client calls to let her social worker know that she is feeling depressed and wants to kill herself. The social worker's first response to this information is A, advise the client to call 911. B, suggest that the client go to the nearest emergency room. C, inquire if the client has a formulated plan. Or D, ascertain whether the client is alone. So someone that you've been working with has just called you on the phone and says, I'm feeling really sad and I want to kill myself. The first thing that you're going to do is, okay, call 911. No, don't do that. This is a client that is established. You're working with them. You're not going to say, okay, call 911. You might do that after, but not first. All right, well, I think you should go to the nearest emergency room. Do you think that someone that's about to kill themselves is going to go to the emergency room? No. And you're not going to ask the client if they're alone, because so what? What if they are alone? What if they're not alone? What's that going to change if she wants to kill herself? You're not going to do that first. So the first thing you're going to do is say, oh, do you have a plan? Because then they might say, yeah, I have a gun right here in my lap, right? So you want to know. Or, oh, I just took a bottle of pills. You're going to call 911 for them, right? So the first thing you're going to do is you're going to inquire if the client has a plan. So that's C. Ask yourself, pretend like you're in the question. It's going to be really helpful. Act out the scenarios in your head, like we just did. Okay, like 26 more slides, guys. Yay, 2 hours, almost done. Here's another practice question. Read the last question. The client is most likely experiencing which disorder? Then read the whole question. A client begins seeing a social worker at the encouragement of family members. Remember, read it slow. Family members are concerned about the client's well-being after losing a long-term job 7 months ago. The client reports being frequently irritable and unable to focus on tasks. The client has also been experiencing muscle tension and insomnia. The client is most likely experiencing which disorder? Now, before I move forward, at the very bottom there it says aswb.org group practice tests. These are retired real ASWB questions, okay? All right. So A, post-traumatic stress. B, generalized anxiety disorder. C, acute stress. D, persistent depressive. So remember, this is a client that is going to you for therapy. at the encouragement of family. So family has referred this client, like, you need to come to therapy, go to the social worker. And the family is worried about the client's well-being because they got fired or for some reason lost their job 7 months ago. The client is irritable and unable to focus. They have muscle tension and insomnia. I already know by looking at this that muscle tension is a diagnosis related to generalized anxiety disorder, but before I jump the gun, I'm just going to eliminate what's just not going with this question. So acute stress and PT and post-traumatic stress, that's related to like something pretty severe. So it's not going to be A or C. And persistent depressive disorder, remember that was like depression for a long time. That was like 2 years. So it has to be B, generalized anxiety. All right, here's another one. Last question. The most likely diagnosis for this client. So we're going to be working with somebody who's having a diagnosis. So we're looking for a diagnosis. And as you can see by the answer choice looking down, they're all diagnosis related. A 40-year-old man comes home after work to find that his wife of 15 years has moved out. She has removed all of the furniture and taken their 2 children. In the initial interview 1 week later, the client tells the social worker that he fears that he will never see his family again. He cries easily and states that he feels confused. The most likely diagnosis for this client is A, persistent depressive disorder. That's 2 years, so it's not going to be that. Post-traumatic stress disorder, that's like from trauma, like something severe, like maybe a rape or something, or an attack. So it's not going to be that. D, major depressive disorder with anxious distress. With anxious distress, remember that was a identifier, a qualifier, adding that on to a disorder. So major depressive disorder is, I believe it was 2 weeks. So this is an interview 1 week later. So it wouldn't be major depressive disorder. It would be adjustment disorder with a depressed mood. You understand? Okay. He's having trouble adjusting to his wife leaving. And he's crying easily because he's feeling confused. Here's another one. Upon initial assessment, a social worker notes that the client's inhibitions and ambivalence towards others could indicate the presence of the client who experienced severe neglect by his biological parents during infancy is brought to a social worker agency for evaluation. According to records, the client lived with several foster families before being adopted at the age of 5. Despite receiving consistent nurturance from his adoptive family, the client has failed to bond with them. Upon initial assessment, a social worker notes that the client's inhibitions and ambivalence toward others could indicate the presence of, so A, Rett syndrome, B, selective mutism, C, separation anxiety disorder, D, reactive attachment disorder. So this is a client who's experienced severe neglect by his biological parents when he was a kid, and he's brought to the social worker for an evaluation. Despite receiving a lot of nurturing from his adoptive family, he still feels that he hasn't bonded with them. So after my initial assessment, I know that the client's inhibitions and ambivalence, meaning unsureness towards others, could indicate. So it's not separation anxiety disorder, because that's when you're separated for periods of time from like someone that's taking care of you and you get anxiety. It's not selective mutism, because that's like when you selectively decide not to talk. And I don't know what Rett syndrome is. So The last one remaining is the reactive attachment disorder. Okay, here's another one. I want you to do a few on your own. These have rationales underneath. Okay, cluster A personality disorder. Cluster A is considered the odd and eccentric cluster with characteristics that include social awkwardness, withdrawal, or avoidance of social settings. These personality disorders include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So we're going to go over a few clusters. It's possible that maybe on the exam, and which each cluster, a cluster of disorders will go under, and there will be a reason why they all are grouped together. So here is cluster A. So here you got a little picture, right? You got paranoid, schizoid, and schizotypal. Remember we said schizotypal was like Willy Wonka, right? Paranoid and schizoid. Odd behavior. And then we got a little description here of paranoid personality disorder. I already kind of talked about it, so on your own time, just kind of look over this for some more details. You're going to need 4 or more of these for this diagnosis. You also want to rule out medical before moving forward with assessing for a mental health disorder. You should always rule out medical. The question will state that the client was referred for an example, an assessment for a mental health disorder, or may just list a bunch of symptoms that could be medically caused or emotionally caused. The answer most likely will be dependent on what the question is asking for. The advice the client needs to see is that they need to see their general doctor. You first need to rule out medical. It's important to rule out medical if they have a lot of different medical symptoms. So here is a question for schizoid personality disorder. Here is more information on schizoid personality disorder. And for this diagnosis, the person needs to have 4 or more of the following. Schizotypal personality disorder, we talked about that already. This is another definition here, explaining more about this disorder. Whatever works for you. Remember things, like remember I said Willy Wonka, right? For schizotypal, 5 or more of the following symptoms. So for example, to diagnose Willy Wonka with schizoid personality disorder, we're going to say that he did kind of have an odd speech. He did have paranoid ideations about the people outside of the factory. He felt that they were stealing his recipes and that they didn't like him. He did have a little bit of a constricted affect. He did have a little bit of an eccentric appearance. He did lack close friends. He did have a little bit of a paranoid and negative fear about himself. So that's already 5 things. So Willy Wonka, I'm sorry, but you have just been diagnosed with schizotypal personality disorder. Cluster B personality disorders are characterized by dramatic, overly emotional, or unpredictable thinking or behavior. They include antisocial personality disorder, borderline personality disorder, histrionic, and narcissistic. So here's a little diagram for my visual learners. That is the link of where I got it from if you want to like read up more on it. But you got antisocial, borderline, histrionic, narcissistic, and then it talks a little bit about that. And antisocial personality disorder, we talked about that. Don't get that confused with somebody that like doesn't want to be social. This is a serious diagnosis. This is a person that does not have any regard for other people, will do anything they want to do. This is a complete disregard and violation of the rights of others since the age of 15. They need 3 or more of these. Narcissistic personality disorder, we talked about that. For this one, they need beginning by early adulthood and present in a variety of instances by 5 or more of the following. So, I think we've all had someone in our life that was at least narcissistic. I can say I knew someone once that had a sense of entitlement, self-importance. They take advantage of others, lack empathy, envious of others, arrogance, and an attitude. That's 5 right there, right? So narcissistic personality disorder, this is a pervasive pattern or fantasy of behavior lacking empathy. Borderline personality disorder, we already talked about that. For someone to have this diagnosis, they need to start having these symptoms in early adulthood and present in a variety of contexts, indicated by 5 or more of the following. So as you can see, most of these diagnoses are 5 or more. Histrionic, this is flashy, like foo-foo type reality TV shows, Paris Hilton, Nicole Smith. I'm not trying to like diss any of them. I love the Anna Nicole Smith show, and I loved the Paris Hilton show. I love that flashy foo-foo reality TV show. I think it's fantastic. But just like if you're going to give them a diagnosis, you might say that they had a little bit of a dramatic personality disorder going on, which based on mental health, it's called histrionic. It's a psychiatric disorder distinguished by a pattern of exaggerated emotionality and attention-seeking behaviors. And maybe this personality disorder really isn't a diagnosis that they have because it's acting. So maybe the actor, script writer wanted them to display a histrionic personality disorder, but in real life, they may not have that. So I'm not diagnosing them. I'm just saying, I don't want to get in trouble for saying that. It may have just been a script thing. Anyway, they would need the following criteria for this diagnosis, and here are some. Cluster C personality disorder, characterized by anxious, fearful thinking or behavior. Avoidant personality disorder, dependent personality disorder, obsessive compulsive personality disorder. Avoidant personality disorder is, we talked about extreme shyness, sensitivity to criticism. This is someone that it could be in a child or an adult. It can be like this shy feeling. It's normal in childhood, and they sometimes outgrow it, but if it continues into adulthood, it can be just like a personality disorder. It's a chronic feeling of like inadequacy, being really sensitive. If you feel like you're being negatively judged by others, you're just not going to interact with them because you're going to be scared that like people are going to be like bashing you somehow. And for this diagnosis, you need 4. So, for example, holding back, intimate relationships, you're worried all the time about rejection, you're worrying about like people making fun of you, not being like at the same level with other people, like being inferior, and you're going to be hesitating to take risks or do new things out of fear of embarrassment. So what's the difference between avoidant personality disorder and social anxiety disorder? Because sometimes they can be confusing. So here we go. Avoidant personality disorder is driven by severe feelings of worthlessness caused by emotional abuse, criticism, ridicule, lack of affection by caregivers, and rejection from peers. Social anxiety disorder is driven by severe anxiety, but a person can be diagnosed with both. Dependent personality disorder, we talked about this, but I just listed this here because it's part of this cluster. They need 5 or more. Obsessive compulsive personality disorder, we talked about this. This is a mental health condition that causes an extensive preoccupation with perfectionism, organization, and control. This is the one that is the more severe of the obsessive compulsive. This is someone who needs 4 or more of these to have this, perfectionist, super devoted to work. They don't delegate work to others because they have an intense fear that the work won't be completed and it'll all get ruined. That's this diagnosis. Here is a question, diagnosis questions on the exam, some tips. So, we kind of went over this in chapter 1, but you can highlight stuff to help you like shine out things in the question if you're like not sure. You want to keep in mind the time frame. That's like really important. The age of the onset is important. It'll help you like rule out like things that might be in children or adults. You need to understand that some symptoms overlap with several disorders, and knowing the main features of the disorder is really important. And for the master's exam, symptom recognition is important, and for the clinical, differential diagnosis. Vicarious trauma is the emotional residue of exposure to traumatic stories and experiences of others through work, witnessing fear, pain, and terror that others have experienced a preoccupation with. Horrific stories told to the professional. Then here's another practice question. I put the rationale at the bottom, so I'll let you do that one on your own. Okay, and here's another one. Read the last sentence first, right? The social worker's response is, so they're asking for what you will respond with. You see how reading the last question helped first? So when you read the question and then you read the choices, you're looking for a kind of response. So client, I'm depressed. I've lost my hair at a much quicker rate than I thought possible. I'm terribly embarrassed to go out in public. I'm feeling extremely anxious and uneasy about my baldness. The social worker then says, you're anxious and uneasy about the transformations that are a natural process of aging. What kind of response am I doing? Am I encouraging the client? No. Am I summarizing what the client just said? No. Summarizing would be, so you're saying that you lost your hair quicker because you're feeling anxious and now you're afraid to be in public because you're bald? That would be summarizing. I didn't do that here. Am I paraphrasing? Did I say, so you're anxious about being in public because you're bald? I'm reflecting on her feelings. You're anxious and uneasy about the transformations. And that's a natural process of aging, right? Okay. And here's another one. This is a one sentence, so you just read the whole thing. Last slide, so let's put everything in it. Thanks for sticking through with me for 2.5 hours. If for those who did not take a break. When treating elder adults with depression, the best approach to treat is A, cognitive behavioral therapy in addition to working with family interventions. B, significant reliance on psychiatry because medication management is most important. C, treatment of elder adults is similar to older adults, so no significant alterations are needed. Or D, coordination between medical and mental health due to the influence of medical conditions on psychiatric symptomatology. So this question is asking you that when you're working with elder adults, so an older aged adult who is experiencing depression, what's the best thing that you should do to help treat this person? Would you do cognitive behavioral therapy in addition to working with family interventions? No, because the question doesn't say anything about like their family being involved. You don't want to add anything in the question. So, and don't assume, don't like create a story, right? Because if you're looking at D, right, being the correct answer, you're going to coordinate between the medical personnel and the mental health due to the influence of medical conditions on psychiatric symptomatology, right? You're working with an older adult here who's experiencing depression and they need a treatment. So depression is a symptom, so it's mental health related. You're going to want to like something with psychiatry, you're going to want to work with them to like feel better. So there's nothing in this question about family being an issue, so you're not going to pick that. B, significant reliance on psychiatry because medication management is most important. This question does not say anything about medication for this client, so don't add anything. That's going to be a ridiculous answer. So it's going to be either C or D. Treatment of elder abuse is similar to older adults, so no significant alterations are needed. That's obviously a ridiculous answer because it's the question is asking for an approach and just saying, older adults are the same as adults, so you don't need to do anything. So you've just ruled out 3 ridiculous answers. So even if D seems like still hard to believe that that's the right answer, if you rule out the answers that you're sure are probably not the right answers, you're going to be left with one answer, and that's going to be the correct answer. So like when I first looked at this question, I did not know it was D. I struggled because they all kind of look maybe A, right? Because it can be confusing when you don't add anything in a question. So you can make a mistake and pick that one because, you're thinking in your head, oh yeah, this is an older adult's depressed, I'm going to get their family involved and help them. Don't add anything in the question. It doesn't say anything about the family being involved. Also, why would you do CBT with an older adult having depression? It just doesn't work. So go through the questions and ask yourself if they work. Put yourself in the scenario of the question. You're treating an older adult with a depression. You still have no idea which possible answer could be. Like, oh my gosh, look at these answers. They're so vague. Oh my gosh. Like even D is vague. But if you go through A through C, you'll see that A through C, they are ridiculous answers. So you're left with D. You might as well pick it. You see what I'm saying? All right. 2 hours and 41 minutes, and we did it. See you in the next chapter.